Okay.
So today the main source of recommendations that we will be discussing is the recently released recommendations from the U.S. Multi-Society Task Force of Colorectal Cancer. We'll be addressing it as the MSTF from now on. And it's a joint commission between the American College of Gastroenterology, the American Gastroenterological Association, and the American Society for Gastrointestinal Endoscopy. And I'll just have a few very simple questions, and then we'll go through the why, the when, and the how. So the first question is, why do we screen for colorectal cancer? And just some boring statistics that worldwide the colorectal cancer is the second most commonly diagnosed cancer in women and third most common in men. And it accounts for almost 700,000 deaths in 2012. That's worldwide. In the U.S., it's the second leading cause of cancer death and accounts for almost more than 8% of the cancer death overall. And just going a little bit more in details, that 1 in 3 people who develop colorectal cancer will end up dying of that disease. And it's infrequent before the age of 40. That's why most of the recommendations will be discussing when it will be done, and it will be 40 or above. And then we'll go through some syndromes that we will have to do the screening in younger people than that. But and generally, it's more common after 40. And the whole reason we do the screening is A, to identify who is at high risk, and then B, if there's a high risk lesion, you end up taking it out and end up preventing colorectal cancer from developing. And then looking at both the incidence and the mortality rate, they've been declining in the U.S. With death rate of the colorectal cancer declining average 2.7% each year. That was the data they looked at between 2004 and 2013, and it continues to decline till 2017. So this is just a graph looking at the different incidence rates by race and ethnicity, and that was a study done between 1999 and 2009, that the numbers they had, and you can see just by looking at the different curves that all the different races do benefit from screening colonoscopy, just screening or for colorectal cancer in general. So that was the first reason, why do we screen for colorectal cancer. The second question is how to screen. The most common method of screening is colonoscopy, but it's not the only one that is available to us. So looking at that, when they looked at the different methods that we have to screen for colorectal cancer, they divided them in 3 different tiers. So the first one is doing a colonoscopy and doing that. And again, this is very general to like just general population at average risk of colorectal cancer. So the first step is doing either colonoscopy every 10 years or an annual fecal immunochemical test. The second tier of methods we have. No, that's not identified as one of the reasons to, or one of the methods to screen for colorectal cancer.
Not necessary anymore.
So it's done as part of the examination when we're doing the screening colonoscopy, but it's not recommended as just a thing to do screening for colorectal cancer during like regular checkups or just like annual physical. Not for prostate cancer maybe, but not for colorectal cancer. Yeah. So the second category is doing a CT colonography every 5 years, or doing the fit fecal DNA every 3 years, or doing a flexible sigmoidoscopy. And then the last 2 that are not really recommended to use, or the last, like if people are refusing all the previous methods, you can try using either the capsule colonoscopy or the septin. And we'll go a little bit in details of the different methods and what's the advantages and what are the disadvantages of each of these. So looking at colonoscopy, of course the advantages include the high sensitivity for cancer and all classes of precancerous lesions. And of course the best thing you get from colonoscopy is that in a single session you are diagnosing and you are treating the high-risk lesions, because you're just there, you take the polyp out, and it's done. The patient doesn't have to come back, or no further interventions need to be done. And on average, if the patient doesn't have higher or advanced lesions, they can do colonoscopies every 10 years, or if it's just completely normal, they do it every 10 years. Of course, the disadvantage of colonoscopies is that it's an endoscopic procedure, it's an intervention, and during the intervention, you're doing either polypectomies or doing biopsies, and with that, you get the higher risk of complications, which is still not terrible. Like, you have risk of bleeding, which is 2.6 per 1,000 cases. Risk of perforation is 0.5 per 1,000 cases. And risk of death, which is 0.029 per 1,000 cases. And the risk of bleeding in colonoscopies, most of the cases, it's related to post-polypectomy bleeding. And, of course, despite all the risks that we talked about, is that the colonoscopy is preferred because of during the colonoscopy, you can manage the benign lesions that you don't really have to go and do any surgical intervention to. So when they did the recommendations, they also came up with questions that the patient should ask the gastroenterologist who's doing the procedure, just to make sure that we're providing high-quality screening colonoscopies. Because, again, like, big part of the screening colonoscopy, if it's also operator dependent. So it really depends on the person who's holding the scope and who's doing the procedure, and how meticulous they are in examining the colon while they're doing it. So these are questions for the patients to ask the gastroenterologist, to see if this is the GI doctor that they should trust and should get the procedure done under their care. So what is the adenoma detection rate? So the ADR, now it's something that has to be reported on all gastroenterologists, and everybody's keeping track of that. And the minimum should really be either 25% overall, or, since it's higher percentage in male, so you should have 30% in male and 20% in female patients. And also the other question would be, what is the rate of cecal intubation? So just making sure that the colonoscopy was completed. And just to clarify in that point, when we're doing screening colonoscopies, it is considered a complete study once you intubate the cecum and you take a look at it. Some GI physicians, they regularly try to intubate the terminal ileum and just peek in the terminal ileum and take a look and make sure that there's nothing there. Other people, it's used mainly for diagnostic purposes. If the patient is coming with iron deficiency anemia or any source of like lower GI bleed, then the GI should be intubated. But just for screening colonoscopies, if you go into the cecum and you examine carefully, that should be considered a complete evaluation. And then now the new thing is, which is like considered standard of care, we still don't use it on all our patients, is using a split dose of bowel prep. So the usual way we would do it here is we ask the patient to start drinking their gallon of Golightly, which is 4 liters of Golightly, start drinking it at like 6 p.m. or 4 p.m. They usually finish by midnight, and then we say midnight, we give them a couple of doses of that Dulcolax, have them stay NPO till the morning, and in the morning we do the screening colonoscopies. All the studies that were done using a split dose of having the patient drink the first 2 liters around that same time, like 4 or 6 p.m., and then going to bed, waking up around 4 a.m., drinking the second half, which is the second 2 liters, and then having the procedure done in the morning. All the studies showed that you get better preps when you split the dose. And again, I feel that most hospitals are going through that transition now. Here, as I said, we don't use that on all our patients. It's not enough. We don't use it in our. We should be going that way. It's just it's more challenging, I would say, for our patients, since it's not just like start drinking it, you're done by midnight and that's it. They should start drinking it, and then they should wake up early in the morning at 4 a.m., make sure that they drink the second half, and then they come. So there's a little problem with compliance, I would say. But if you have a patient that you enforce the importance of following the directions, if you have very clear directions, no confusions, people should be usually able to do that. And all the studies they did, if the patients are giving very clear instructions and the importance of why we're doing it this way, they get really compliant with it, because it's like, I don't want to repeat my procedure. I want to be done with this. So they kind of take the leading role, and they do follow. Here, we're just having some concerns about that, but I feel that we're heading towards that.
Let me ask you, since it's something very common, are there any guidelines written regarding aspirin and clopidogrel,
So
or what doing elective colonoscopy?
yeah, so that's a very, very big question, and that like applies to everything from aspirin, Plavix, all the way to the NOACs and the Xareltos and the Plavix and the Eliquis and all the medicines that we're using now. And a big part of it says it's it's left to like expertise opinion. You need like the cardiologist or whoever, like the neurologist, whoever is giving the patient the anticoagulants should discuss that with the gastroenterologist, and they should come up with a decision about that.
I know what we want.
Yeah.
I want to know what you want.
So
How comfortable are there guidelines?
As a general rule, you don't stop aspirin.
yeah.
What about Plavix?
You can continue the aspirin for
Plavix?
everyone, for the grill. The Plavix 5 days before the procedure.
Coumadin?
3 days before the procedure, and then it depends on whether you need to wish
The NOACs?
So the NOAX is different for each one. Depends
So
on
you don't,
sometimes 12 hours, depending on the half-life of the
so
NOAX.
you don't want to do colonoscopies on 24 hours.
Now, doing colonoscopy is okay. Now, what we intervene is the issue. Okay. Biopsy, simple biopsy should not be an issue. If you have polypectoral, there we are concerned. So, even though prophylactically we tend to clip the areas, still they tend to be bleed. So, there's no consensus.
Are you very against, or are there any recommendations against the Plavix? That's a specific question.
And minimum 3 days we say, but I think we can have a detailed lecture on this one of these days on all the new anticoagulants put together.
Well, we do have a grand rounds on anticoagulation coming up. Maybe we could, on December 8th, maybe we should put that in to ask them to talk about.
That should complete all the year. There are different charts that can build up, and each medicine, how many days to stop it, and what the implications, lots of details.
Yeah, like we do our rotations between here and Metropolitan, and like we were saying, like the aspirin shouldn't be stopped on the Metropolitan. Like some physicians ask to be stopped. It really depends on you, how comfortable you are, and how. Yeah, yeah, and yeah, like on like some gastroenterologists, they're okay with even continuing the Xarelto, because the way they look at it is like, okay, you stopped the Xarelto like 12 hours before the procedure, but their way of thinking was like, well, you stopped it, but it's still the half-life, it's still there, it's still in the system.
12 hours is not
Yeah,
enough.
yeah,
You're not really stopping.
12 hours.
yeah.
Not
Right.
really-
No, each one is different. I think
Each one is different.
No, no.
So I think the topic coming up with focus.
Okay.
Okay.
Thank you. And then, so these were the questions that they recommended for the patients to ask, so that they make sure that they're getting a high-quality evaluation. So the first thing we talked about was the colonoscopy. The second thing was the FET test, which is the fecal immunochemical test. So the FET is more specific than the guaiac that we used to use, because it only detects the human globin, and it doesn't detect upper GI bleeding. So it's really interesting. I'm not going to say where, but like in some ERs, they use the FET to detect if there's like the patient is having any GI bleed. They don't realize that if they're using the FET, they're missing any upper GI bleed. They're only detecting lower. So they do it as like, oh, the patient doesn't have GI bleed, and they need to be educated a little bit about that part of it. And the advantages of the FET is that it includes non-invasive nature. It's just a test that is done on the stool sample. And just doing it for one time sensitivity detects up to 79% of the cancers. And for the advanced adenomas, it's about 30%. And the cost of it is the most attractive part of it, which is only $20 for one test. So the FET now is recommended to be done annually in the United States. Disadvantages include the need for repeated testing, and because it's done annually compared to the colonoscopies, which can be done every 10 years. And the right group of patients. And then the other thing is that the poor or actually no sensitivity for serrated class precursor lesions, and we'll go through that as well. The third test that we have is adding the FET to the fecal DNA test. So you're doing both. You're doing the fecal immunochemical test and adding to that detecting DNA testing, and that is commercially available as Cologuard. And Cologuard is FDA approved. It's Medicaid and Medicare approved as well. And the recommendations for the FIT plus the fecal DNA test is every 3 years. The advantages includes the highest single time testing sensitivity for cancer of any non-invasive, non-imaging colorectal cancer screening test, and it has a one-time sensitivity to 92% compared to here, which was only 79%, and 40% for the polyps. The disadvantage is the substantial decrease in the specificity. So you're picking up more patients, so you're getting a lot of false positives. So this is the number that these people, when they end up, because once you get a positive test, the next thing you do is to do a screening colonoscopy, and in that case, you get a lot of just normal colonoscopies, and nothing really is there. And that's compared to 96% for the people who only got the FET without adding the DNA test to that. And of course, here, because you're adding an extra test, it's a higher cost. So the conclusion at the end was that the annual FIT is more effective and less costly than the FIT fecal every 3 years. The fourth way of screening for colorectal cancer is doing a CT colonography. And the advantage of the CT colonography is that it's a low risk of perforation compared to the colonoscopies. Again, because it's not an interventional procedure, you're not doing really anything, you're not resecting anything, you're not biopsying anything, and then the sensitivity is 82 to 92 for adenomas more than 1 centimeter in size. The disadvantage of the CT colonography is that the use of the bowel prep, and we'll go through discussing that. So the sensitivity of the CT colonography for polyps less than 1 centimeter is less than the colonoscopy, and detection of the flat and serrated lesions are major deficiencies in the CT compared to just the standard colonoscopy. And of course, the radiation exposure is generally viewed as a disadvantage. So when used, if again, as we discussed, this is something that you have, all these options are available, and you have to discuss with the patients. You'll tell them what's the highly recommended. If they end up refusing that, you'll go to the second tier and you tell them well, instead of just not doing anything, what about doing something that is less invasive and requiring less requirements of taking the PrEP and drinking all that and then coming to the hospital and going under sedation or analgesic sedation. So when used, if you end up using the CT, it's recommended every 5 years in patients with normal CT colonography. Patients with polyp more than 6 millimeters in size seen on the CT, they should undergo a colonoscopy. The fifth method we will talk about is the flexible sigmoidoscopy, just looking at so with the flexible sigmoidoscopy, you can go up to 60 centimeters looking in the colon. So it's obvious that the advantage include lower cost and risk compared to the colonoscopy, and it's a more limited bowel preparation because you're not cleansing the whole colon, you're just doing the distal part of it. And then the disadvantage that you're missing the looking at the whole right side of the colon and missing anything that could be detected on a regular colonoscopy. The sixth thing is just using a capsule endoscopy. We know the capsule endoscopy is when we can see something with an EGD, or we can see it with a colonoscopy, or if we think it's somewhere in the small intestine, we do the capsule endoscopy. This one is capsule colonoscopy. You make the patient swallow the pill, and then you just follow it till all the way through the colon. So now there's limited approval for the capsule colonoscopy. So it has been approved by the FDA for imaging of the proximal colon in patients who had an incomplete. Remember, we said to have a complete screening colonoscopy, the cecum has to be intubated. So if the patient has a tortuous colon, or for whatever reason, acute angulation, the endoscopist couldn't complete the evaluation of the colon. One of the things that's now approved by the FDA is using capsule colonoscopy to look at the part that was missed by the colonoscopy. And now it's also approved for people who have colorectal imaging but are not candidates for colonoscopy or sedation for whatever reason, if they're high risk for the procedure, if they're refusing it, if they're unstable enough to get under sedation. The advantages of the capsule colonoscopy includes the achievement of endoscopic imaging without any invasive procedure. and avoiding the risk of colonoscopy. And the disadvantages include the more extensive bowel preparation than for colonoscopy, because it really has to be completely clean. You don't have the option of being there. It's like, well, there's something there, I'm going to clean it myself and take a good look. With the capsule, you don't really have the option. It has to be very, very clean so that you get good quality pictures. Also, most patients with positive studies will require repreparation, because the patient is coming in to do a capsule procedure. So once that is done around like 6, 7 p.m., and if there's anything shown on that, it was like, well, we'll have to now have you come back, prep again, and schedule it for colonoscopy. So that can be like a lot of hassle to the patients, and they might not be very happy with you if you end up doing that. So the capsule colonoscopy has 88% sensitivity for detecting patients with conventional adenomas, more than 6 millimeter in size, but it was really ineffective for the detection of the serrated lesions. I'll go quickly through the last couple options we have. The Septin9 assay, that was the first FDA-approved serum test for colorectal cancer screening. So this is a blood test that you do, and then you tell the patient if they have anything positive or if it's not. And the Septin is just Septin9 is a plasma assay. As we said, you detect the methylated Septin9. It has a sensitivity of 48% for detection of colorectal cancer and no sensitivity for detection of precancerous polyps. And the advantage, of course, includes that it's a serum, it's a blood test. The disadvantages include the markedly inferior performance compared to all the other ways we have to detect colorectal cancer, including even the FET. And that's why it's really now, they don't even have a recommendation for how frequently you should use it. So that's why it was in the very last tier of options we have to detect colorectal cancer. So we said why we do it, how we do it. Now the last question is when to screen for colorectal cancer. And this is when it gets really high yield board examination for medicine. They just love this part of it. So the MSDF recommendations, this was their latest recommendations, is begin screening for non-African American average risk person at the age of 50. And then they just added that if the patient is an African American, you should start doing it at the age of 45. But then the quality of the evidence wasn't strong enough, but they still did put the recommendation in. And then for any patient less than 50 with any colorectal bleeding symptoms or anything significant enough, like as listed here, on either like hematochezia, unexplained iron deficiency anemia, melena, with a negative upper endoscopy, you should follow up and do a colonoscopy on that patient. But that's really should be considered a diagnostic colonoscopy, not a screening colonoscopy. And then if the patient started having their screening colonoscopy at the age recommended, at the age of 50, and then they get to the age of 75 and they really don't have anything significant and all their studies have been okay, then the recommendations is that you can stop doing screening colonoscopies on these people at the age of 75. And then if somebody comes in older than that, but they never had a screening colonoscopy before, or they were not really compliant with their procedures, you can still continue to do it up to the age of 85. So this was their general recommendation for general population. And then we'll get a little bit in more detail. So just going through that. So average person should be at the age of 50. There's low quality evidence that if the patient is African American, you should start at the age of 45. And then if the patient start doing their procedures 50 to 75, you can stop at 75. By going through a little more details here in certain situations. And I'm going to go, so I'll just go quickly with the Lynch, and then we'll talk more about the Lynch later. So if the patient has Lynch syndrome, you should start doing their colonoscopies at the age of 20, and then do it every 1 to 2 years. And then if the patient has family colon cancer syndrome X, we'll talk about the difference between these two. You do their colonoscopies every 3 to 5 years, beginning 10 years before the age at the diagnosis of the youngest affected relative. And so these are the two syndromes. The colorectal cancer or advanced adenoma in a first-degree relative diagnosed at any age, or colorectal cancer in one relative that happened before the age of 60, you do it either at the age of 40 or 10 years before. I feel most of us familiar with that one, that if there's two family relative or one that is a first degree relative, you start earlier at the age of 40 or 10 years before the age of diagnosis of that relative, and then you do it more frequently. You do it every 5 years. And then here they mention something, because they also like that in the questions section, when they talk about, they will tell you, like, they'll try to trick you that, like, the patient is coming in and they have a relative, first degree relative, but it was diagnosed after the age of 60. So in that one, you do it if you start at the age of 40, but then the follow-up is every 10 years. They don't get more close follow-up every 5 years if their colonoscopies are negative, or the method you use is negative. You can just do it every 10 years. So just going through these syndromes, like, really quickly. So in general, just talking about the hereditary non-polyposis colorectal cancer, you have to have all these criteria. So the Amsterdam 2 criteria, you have to call this a hereditary non-polyposis colorectal cancer. You have to have 3 relatives with any Lynch syndrome-associated cancer, which is colorectal, gastric, small bowel, endometrial, ovarian, or urinary tract cancer. And this section is really, really important, because they will trick you and they will give you a patient with Lynch. They're not going to tell you the patient has Lynch, but it's obvious from the question that the patient has Lynch. And then they'll ask you what else should be done. What else do you need to test the patient for? The obvious thing will be to do colonoscopy, but they will ask what else you need to do. So it's really important to remember that Lynch syndrome people, they have higher incidence of colorectal cancer, gastric, small bowel, endometrial, ovarian, and urinary tract cancers. So you'll have to have 3 relatives. You have to have one of these relatives should be a first-degree relative, and then you should have 2 successive generations. Should be like a grandfather and a father, or like a father and a son, that they have the syndrome. And then one of them should be before the age of 50, and then the familial adenomatous polyposis should be excluded. Shouldn't explain that colorectal cancer in this patient. If they have familial adenomatous polyposis, that doesn't count here as one of these cancers. You should look for either gastric or like ovarian or urinary tract cancers. And the tumor should be verified, of course, by pathological examination. This should be a tissue biopsy confirmed cancer, not just like there's a mass in the colon, there's a mass in the ovary, this patient has Lynch. No, it has to be confirmed by a tissue biopsy. So these are the general rules for the hereditary non-polyposis colorectal cancer. And then just to go a little bit, because that can get confusing, what are the differences between the Lynch syndrome and the familial colorectal cancer type X? So both of them have the hereditary non-polyposis, but the difference is in the Lynch, you have the gene mutation. You test the patient, and they do come back positive for the hereditary DNA mismatch repair gene. In the familial colorectal cancer type X, sometimes they call them the other half of Lynch, which is people with hereditary non-polyposis, but their genetic testing came back negative. So if you only have that, but you have negative genetic testing, you call them familial colorectal cancer type X. So this is another syndrome, the serrated polyposis syndrome, or the hyperplastic polyposis syndrome. This is a rare condition that is characterized by multiple large and or proximal serrated polyps. And the way to diagnose that one is you should have at least 5 serrated polyps proximal to the sigmoid colon, and 2 or more of them should be more than 10 millimeters. Or you can have any number of serrated polyps proximal to the sigmoid in a person who has a first-degree relative with the syndrome. And then if more than serrated polyps of any size throughout the colon, that's also a diagnostic finding. So you should have one of these 3 to call the patient or to label the patient of having serrated polyposis syndrome. The last one I'm going to talk about is the familial adenomatous polyposis, and this one is the presence of multiple colorectal adenomas, typically more than 100, and usually it's hundreds in number. And it's a variant of the germline mutation in the tumor suppressor gene, the APC, and they sometimes like this question in the board as well. They'll ask you, like, in the process of having an adenoma transforming into a cancer, what is the first gene? If the patient is coming in with that, like, what is the what gene is like responsible, or the mutation in which gene you should be expecting for this patient to have if they're having a accelerated rate of the adenomas turning into carcinomas or cancer. And the APC gene is the first one that you should be looking at. And screening for colorectal cancer by annual colonoscopy should be performed beginning at puberty. So familial adenomatous polyposis, Lynch, we said 20 years. Familial adenomatous polyposis at the age of puberty, which gives you the youngest age of people who should have screening colonoscopies. So once you do a colonoscopy and you find a lesion, anything after that, once you find a polyp of any sort, any colonoscopy you do after that to follow up on this polyp or on this patient, it's called surveillance colonoscopy. So the first one, you're doing it if the patient is completely asymptomatic. You're looking at for the whole purpose of looking for colorectal cancer and preventing colorectal cancer from happening. That's a screening colonoscopy. If you find polyps and then you following up on that patient, in that case, it's a surveillance colonoscopy. And the things you need to look at, and that is the histological classification of the polyps. So the two big categories are either the conventional adenomas or the serrated lesions. So with the conventional adenomas, which I'll call this just the tubular adenomas, you look at two things, the level of dysplasia and if it's tubular villus or villus, and then the dysplasia, you're looking at the high grade or a low grade dysplasia. So conventional adenomas, which are the tubular adenomas, you look at the dysplasia grade and the velocity, and then the serrated lesions, it's divided into three categories, either the hyperplastic polyps, which are not considered precancerous, or the sessile serrated polyps, and the traditional serrated adenomas. Gets really a little too complicated, like going through the differences and histological differences between the sessile serrated and the traditional serrated adenomas. So I think we can leave that for another session. But just knowing that when you find a polyp, what matters after that is the histological classification of the polyp. And just to make it a little easier, you want to define the polyp as is it a low risk or a high risk adenoma. So a low risk adenoma is either 1 to 2 tubular adenomas that are less than 10 millimeter in size. So if you have tubular adenoma, either 1 or 2, and they're small in size, less than 10 millimeter, some places you'll find it 1 centimeter, so 12 millimeters, it's fine either way. That's a low risk adenoma. High risk adenoma, you have 3 or more, so you have numbers, either 3 or more, or advanced adenoma from a histological standpoint, which is 10 millimeter in size, so you have the number 3 or more, and then the size 10 millimeters or more, or if it has any villus histology or high-grade dysplasia. So these are pictures of some of the different kinds of polyps and just how you can identify them, just looking without like any pathological examination. And I just put it just for you guys to take a look at it. It's really, you're never going to be tested on your boards to like, they're not going to show you a polyp. It's like, oh, is this like a, yeah, that's not going to happen. What they will test you on, they will just test you on the, they'll give you the number, they'll give you the size. You need to know the number, the size, the histological examination regarding the dysplasia and regarding the, if it's villus, tubular, or tubular villus. But just identifying the lesions just by eye, that's not something you'll be tested on. So this is the surveillance, and these are the guidelines that we need to tell the patients. Okay, you came for your screening colonoscopy, and then we found you end up being in one of these categories. So if we do the colonoscopy, there's absolutely nothing there, then your follow-up examination should be 10 years. You'll find it sometimes that in reports that you'll be looking at is like it's completely normal screening colonoscopy, follow-up come back in 5 years. If you're wondering why that is, it's just the gastroenterologist either not comfortable waiting for the patient for 10 years because like, well, what if I missed something and I'm leaving the patient to wait for 10 years? It's like, well, maybe if you do a full high-quality exam, you're not going to have any of these concerns. Or if they just want to do more procedures. So just in general, the screening colonoscopy is absolutely negative. Patient should come back in 10 years. If you have small, which is less than 10 millimeter, hyperplastic polyp, rectum or sigmoid, again, 10. So hyperplastic, just if you read a report and you see the word hyperplastic in the left colon, like consider this as if nothing. Like, don't pay attention to it. If it's 1 to 2 small tubular adenomas, that will put you in the category of 5 to 10. If you're going up in the, remember what we were talking about here with the high-risk adenomas? So if you see any of these like red flags, so if you see 3 or more, if you see size more than 10 millimeter, or if you see high-grade dysplasia or tubular, that will put you in the category of follow-up in 3 years. And the serrated lesions as well put you in that 3 years. And then the second part is just talking about the sessile serrated polyps. If it's less than 10, you'll get 5. If it's sessile serrated polyp more, that will put you in the 3. And then the serrated polyposis syndrome, which we talked about here. The serrated polyposis syndrome, which we either you need one of these options to qualify to be one of this. That will give you a follow-up surveillance in 1 year. So we'll just go through a couple questions just to have you look at the numbers and try to make it a little bit clear. So who wants to take a shot at the first question? Dalia, do you want to do the first question first? Yeah.
Read it. And also have to answer.
Okay.
50-year-old woman is healthy and requests screening colonoscopy. During colonoscopy, 5 sessile polyps were found and completely resected. All polyps were 5 to 9 millimeters in size. The pathology came back as tubular adenoma for the 5 of them. Her family history reveals that her maternal grandfather had colon cancer at age 80. Based on the published guidelines, what should be recommended for surveillance? Colonoscopy in 1 year, colonoscopy in 3 years, colonoscopy in 5 years, 10 years, or a fecal occult blood test in 5 years. Maybe you can answer since you're next to me.
Just say,
Yeah. So it's 5 tubular adenomas.
I'll give you that cheat sheet. Just tell me the 2 information that you have listed here, and I'll take you back to the to where we're getting this information. So here you have 2 information. You have that the patient has 5 tubular adenomas, and then the second part is the the relative that is age more than 80, right? So yeah. So and the size. So you have the size. So that doesn't qualify. That's not an advanced adenoma, right? So you can disregard that part. And then the number 5, is that low or risk or high? So that's high. So that automatically puts you in the, yeah. And then, do you really care if she has a relative at the age that was in the age of 8? No. So that's just a trick that they can put there, and like, you need to know. Yeah. Okay. So question number 2.
After performing the first ever screening colonoscopy on a 65-year-old man, the colonoscopic examination reveals 5 diminutive, less than 5 millimeter polyps in the rectum, and sigmoid colon in the medium internal hemianus. Polyp path came back as hyperplastic polyps. Based on published guidelines, the patient has increased risk for familial polyposis, recurrent giant testing, slight increase in risk for colorectal cancer, GP colonoscopy 5 years, marked increase in risk for DV colonoscopy 1 year, no increase in risk, no surveillance need for 10 years, moderate increase in risk, GP colonoscopy 3 years. So 5 polyps were very diminutive, and I guess hyperplastic
So remember when we were talking about the size, the number, the histology, we were talking about tubular adenomas, right?
Right. So this is not really.
Mm-hmm. Yeah.
hyperplastic is the same as
Yeah.
wow.
Yeah. Okay. This is the.
55-year-old lady diagnosed with 2 synchronous colon cancers underwent resection. Genetic testing for MSH2 occurred in germline mutation. Patient's children undergo genetic testing, and his 30-year-old daughter is found to have the same germline tumor. In addition to colonoscopy of this time, what should be ordered? Imaging and CT abdomen.
So remember what we talked about with Lynch, right? What kind of cancers can they get, and how do you want to screen them for these cancers?
You can get ovarian, you can get urinary tract.
Mm-hmm.
I would go with CT abdomen.
So yeah, so that's why this question is very tricky. So CT abdomen is not recommended as the screening way for these patients. And then so what matters is her age. So from this, we all agree that this is Lynch, right? Yeah. So this is Lynch, and then the patient is going to go for a colonoscopy. But what else should the patient go? And again, that's a very tricky situation. If it was a transvaginal ultrasound, that would have been, because if you're looking for, yeah, if it's transvaginal, that would have been the correct answer or one of the correct answers. But since it's transabdominal, that's not recommended. Capsule endoscopy, I feel that it will always be a wrong answer in a screening question. So the correct answer is actually A, which is just doing a UA. So just for sake of completion, the things that you should do is colonoscopy every 1 to 2 years, starting at the age of 20, pelvic exam with endometrial sampling, and as we said, the transvaginal, and you start doing that at age 30. So you're looking for the endometrial and the ovarian, and then you're also doing upper endoscopies to look for the gastric part of it, and then the last thing is the UA you do annually, and they start at the age of 30. So that's a tricky question, but I felt it was interesting since you know what it is, but then you're looking through the options, and you just need to be familiar with what you're using for screening. So UA is the correct answer, and that was the last question I have. If you guys have any questions for me. Yep. So you're looking for blood or anything if you need to do any more further investigation in that case.
So for the fit testing, is there any plans to bring it to our hospital, or what's the?
So the fit testing is something that we should use.
I've seen a few patients coming for colonoscopies after they had a positive test.
Yeah.
I don't know how to order it, but I think they have maybe primary there.
Has anyone here ordered the fit test?
They-
My Wes does it. I've ordered it in my office.
I think some of the residents did. They
Order
said
it.
they haven't been able to.
They have not been able to.
Mm.
But let me send Dr. Del Rosario an email now.
Do we do CT colonoscopy?
We really don't. Yeah.
Not really, no. We used to do it a few years ago, but for some reason, all of these tests were like poor preps and like limited exams, so we eventually in the end we just stopped doing them.
So here if we try to if that colonoscopy was incomplete, there was like a second attempt and we can't really do it. Do we follow up with like a capsule colonoscopy, or what's our
We send them out for
send them out for? Okay. Okay. Yeah.
because, I think it requires like specific someone who's like specifically trained
Yeah.
doing them in radiology.
In the U.S., it's more challenging than in Europe. In Europe, they don't prep the patients; they just give them the contrast. Here, we have to prep them first and then give them the contrast. So that's why it's also like not very liked by patients, because they're going through the whole prep of getting a colonoscopy, but they're not. They're getting a screen like a CT, and then if that comes back with anything positive, it's like, well, prep again and come back for a colonoscopy. So, yeah.
What about any other ethnic groups other than African American age 45? Because we noticed here that we see patients with earlier colon cancer.
Not in the guidelines, as far as I know. Nothing in the guidelines other than just 45 African Americans that is recommended to get any younger or any earlier screening colonoscopies.
But even for the African Americans, it's weak evidence.
The evidence were weak. Yeah. Yeah.
And then did you go over if you have relatives?
Yeah. That was the.
Probably got a phone.
Yeah, it was that part that we discussed like you start at 50, and then what are the special cases? Yeah, like if you have relatives and the age they're getting it. Yeah.
I'm sure they're going to ask you
Yeah.
questions about this.
I'll be around.
Yes,
Yeah,
yes.
absolutely yes, absolutely yes. Yeah.
Question.
As far as you're just like the question will be long, and they'll go in and out of like all kind of details that are really irrelevant. You just need to know the things that we talked about: the number, the size, the histology, and if it's a tubular or just a hyperplastic. And just like you'll look at the key words and you'll be able to answer the question correctly. Don't pay attention to all the stuffing that they will have in there for you. Well, thank you guys for your time.